Hello guys, today we will be discussing about the management of an avulsed tooth which is due to some trauma. When we look at the epidemiology of this tooth avulsion, it is seen in 0.5% to 16% of all the dental injuries. And most commonly avulsed teeth are maxillary incisors, no matter it is primary dentition or it is permanent dentition. Amazingly, the avulsion injuries are 3 times more frequent among the boys as compared to girls. Probably boys are more into the sports or they are more active, and that is why it happens among the boys more frequently. It occurs most commonly among the children between the ages 7 to 9 years. It is that time when the permanent incisors are erupting and not yet reached to their full eruptive stage. Mostly in class 2 incisal relationship, it is very common. They are prone to have trauma because of the incisors are proclined. In 1981, Anderson suggested that the loosely structured periodontal ligament surrounding the erupting teeth favors complete avulsion upon the impact from trauma to the anterior region of upper jaw. Solution is replantation, if it is possible. Immediate replantation. Prognosis in most of the situation, if it is carried out immediately, it has good prognosis. It is the treatment of choice. Appropriate emergency management and a treatment plan are important for a good prognosis. There are few reports in the literature of these techniques proving successful for indefinite periods of time. In 1976, Berry reported on functioning teeth that were replanted 42 years ago. The success of the replantation procedure is undoubtedly related to the length of time that elapses between the loss of the tooth and its replacement in the socket. Hence, time matters. In a study, it is reported that those avulsed teeth which were replanted within 30 minutes, 90% showed no discernible evidence of resorption 2 or more years later. And in the same study, it is reported that 95% of the teeth replanted more than 2 hours after the injury, they showed root resorption. Again, time matters. As I say, time matters. If the tooth has been out of the mouth for under 30 minutes, the prognosis is therefore more favorable. And in the board exams, question comes on it with the option of 30 minutes. We have to choose 30 minutes as our option. The correct answer. How much time? It should be out if less than how much time it should be out. For the best prognosis, it is 30 minutes. Well, other factors which play vital role in the prognosis: healthy periodontia. Immature tooth where the apices are not yet closed, it has better chances of success. In mature teeth, pulpectomy is indicated after few days of replantation. Where the apices are closed, after few days of replantation, you have to go for pulp extirpation, and later you will be performing the endodontic complete procedure, root canal treatment with obturation. When we look at the latest guidelines for management, the International Association of Dental Traumatology, which is IADT, it has developed a consensus statement after an update of the dental literature and discussions among the expert groups. Immediate replantation of the avulsed tooth is the best treatment at the place of the accident. Immediate replantation, if parent can do right at the site of accident, or even if the patient themselves they can do it. If for some reason this cannot be carried out, there are alternatives such as using different types of storage media. If a tooth is avulsed, make sure it is a permanent tooth. We are not going to replant the primary teeth. Primary teeth, they should not be replanted. Remember this thing. Usually question comes on this as well. The patient is 5 years old and their one of the primary central incisors avulsed. So what would be the next stage, or what would be your treatment of choice, or what will you guide to the parent if they are calling you? If we remember this point that primary teeth should not be replanted, so any case scenario which will come in our exam, we will easily answer that question. First aid for avulsed teeth at the place of accident. Keep the patient calm. Find the tooth and pick it up by the crown, the coronal portion or the top portion, the white part. Avoid touching the root. Attempt to place it back immediately into the jaw. If the tooth is dirty, rinse it gently in milk, saline, or in patient saliva and replant or return it to its original position in the jaw. It is important to encourage the patient, guardian, teacher, other person to replant the tooth immediately at the emergency site. Once the tooth has been returned to its original position in the jaw, the patient should bite on gauze, a handkerchief, or a napkin to hold it in the place. Some of the authors, they say while you are placing it in the socket, then hold it there for at least 5 minutes. So there is one option that as well. If replantation at the accident site is not possible, or for other reasons when replantation of the avulsed tooth is not feasible, for example an unconscious patient, place the tooth as soon as possible in the storage or transport medium that is immediately available at the emergency site. The tooth can then be brought with the patient to the emergency clinic. See a dentist or dental professional immediately. What are these storage media? To avoid dehydration of the periodontium of an avulsed tooth, if it cannot be replanted immediately, it should be placed in the storage medium and carried to the dentist as soon as possible, preferably within 30 minutes. Milk is the most preferred medium. Then comes the Hank's balanced salt solution. Previously, like a couple of years ago, we were having the HBSS or Hank's balanced salt solution as number one top priority, but now with the latest guidelines, milk is the top priority. So in your exam, if they will ask you what is the best medium, it is milk. And after these two comes the saliva of the patient. If they spit it into the glass, for instance, never keep in patients oral cavity under the tongue. There would be a chance that patient may choke. Or you can keep it in saline. These are the suitable media. Well, the choice of treatment is related to the maturity of the root, whether the apex is open or closed, and the condition of the periodontal ligament cells. The condition of the periodontal cells is dependent on the time out of the mouth and on the storage medium in which the avulsed tooth was kept. Minimizing the dry time is critical for the survival of the periodontal cells. After an extra alveolar dry time of 30 minutes, most periodontal cells are non-viable. Again, I am telling you our answer would be 30 minutes. Important point is the information regarding the dry time of the tooth prior to replantation or prior to being placed in a storage medium is very, very important to obtain as part of the history, because the prognosis depends on that and you have to inform the patient about this. Classification of the periodontal ligament following avulsion. It is important for the clinician to assess the condition of the PDL cells by classifying the avulsed tooth into one of the following three groups before commencing treatment. Number one, the PDL cells are most likely viable. The tooth has been replanted immediately or within a very short time, about 15 minutes at the place of accident. The PDL cells may be viable but compromised. The tooth has been kept in a storage media like milk or the Hank solution or saver tooth or similar product or saliva or saline, and the total extraoral dry time has been less than 60 minutes. The PDL cells are likely to be non-viable. The total extraoral dry time has been more than 60 minutes regardless of the tooth have been stored in a medium or not. Treatment guidelines for avulsed permanent teeth with a closed apex when the tooth is already implanted by the parent or patient. Clean the injured area with water, saline or chlorhexidine. Verify the correct position of the replanted tooth both clinically and radiographically. Leave the teeth in place except where the tooth is malpositioned. The malpositioning needs to be corrected using just slight digital pressure, means using your fingers to just replace it. Administer local anesthesia if required, but preferably use local anesthesia without vasoconstrictor, plain local anesthesia. If the tooth or teeth were replanted in the wrong socket or rotated, consider repositioning the teeth into the proper location within 48 hours after the traumatic incident. So, if it is placed, you can still remove it from the socket and place it back into the correct socket, or you can reposition it within next 48 hours of the accident. Stabilize the tooth for 2 weeks using a passive flexible splint. Question also comes, what is the time for the splinting? It is 2 weeks. And what kind of splint? It is passive flexible splint. It could be a wire of a diameter up to 0.016 inches or 0.4 millimeter bonded to the tooth and adjacent teeth. Keep the composite and bonding agents away from the gingival tissues and proximal areas. You can also use the nylon fishing line, the lines you use to fish. You can use that as well with the composite to bond it. Nylon fishing lines should not be used if only few permanent teeth are present. Suture the gingival lacerations if present. Initiate the root canal treatment within 2 weeks after replantation. Administer systemic antibiotics. Check the tetanus status. Provide post-operative instructions, and then there will be a we have to follow up the patient. Here we can see this is the tooth splinting with composite resin and the fishing line, and here the sutures are placed. Well, treatment guidelines for avulsed permanent teeth with a closed apex and brought to the clinic within 60 minutes in a storage medium. If there is visible contamination, rinse the root surface with a stream of saline or osmolality balanced media to remove the cross debris. Check the avulsed tooth for surface debris. Remove any debris by gently agitating it in the storage medium. Alternatively, a stream of saline can be used to briefly rinse its surface. Put or leave the tooth in the storage medium while taking a history, examining the patient clinically and radiographically, and preparing the patient for the replantation. Administer local anesthesia, preferably again without vasoconstrictor, plain local anesthesia. Irrigate the socket with sterile saline and do not curate the socket. Remember this. Examine the alveolar socket. If there is a fracture of the socket wall, reposition the fractured fragment into its original position with a suitable instrument. Removal of the coagulum with a saline stream may allow better repositioning of the tooth. Replant the tooth slowly with slight digital pressure. Excessive force should not be used to replant the tooth back into its original position. Verify the correct position of the replanted tooth both clinically and radiographically. Stabilize the tooth for 2 weeks using a passive flexible wire of a diameter up to 0.016 inches or 0.4 millimeter. Suture the gingival radial lacerations if they are present. Initiate root canal treatment within 2 weeks after replantation. Administer systemic antibiotics. Check the tetanus status. Provide post-operative instructions, and then there will be a follow-up. Treatment guidelines for avulsed permanent teeth with a closed apex when extraoral time is more than 60 minutes. Remove the loose debris and visible contamination by agitating the tooth in the physiologic storage medium or with gauze soaked in saline. Tooth may be left in storage medium while you are taking the history, examining the patient clinically and radiographically, and preparing the patient for the replantation. Again, whenever you will be giving local anesthesia in these cases, it should be preferably without vasoconstrictor or plain local anesthesia. Irrigate the socket with sterile saline. Examine the alveolar socket. Remove coagulum if necessary. If there is a fracture of the socket wall, reposition the fractured fragment with a suitable instrument. It should be a blunt instrument. Most probably you can use a ball burnisher for that purpose. Replant the tooth slowly with slight digital pressure. The tooth should not be forced back to place. Verify the correct position of the replanted tooth both clinically and radiographically. Stabilize the tooth for 2 weeks using a passive flexible wire of a diameter up to 0.06 inches or 0.4 millimeter. Suture if the gingival lacerations are present. Initiate root canal treatment within 2 weeks after replantation. Administer systemic antibiotics and check tetanus status. Provide post-operative instructions and then follow up. Well, usually a question comes, patient calls you and they say that their child's tooth has been knocked out and they tell you the age. If you feel that it is going to be a permanent tooth, then tell them to hold the tooth with the crown, not with the root. Then, if it is visibly soiled, then only rinse it using the warm water. But it is not necessarily, and do not use any cleaning agents like a toothpaste or any scrub, or do not scrub the tooth. Try to place it back in patient's mouth if they can. If they cannot, then place it in milk or any other suitable medium and rush to the dental clinic immediately because time matters. Important points: delayed replantation has a poor long-term prognosis. The periodontal ligament becomes necrotic and is not expected to regenerate. The expected outcome is ankylosis related root resorption, which we also call replacement root resorption. Usually a question comes on that most commonly after the tooth replantation, what type of root resorption occurs? It is replacement or ankylosis related root resorption. So we have another answer over here. The goal of replantation in these cases is to restore at least temporarily aesthetics and function while maintaining alveolar bone contour, width and height. Therefore, the decision to replant a permanent tooth is almost always the correct decision. Even if the extraoral dry time is more than 60 minutes, replantation will keep future treatment options open. Now, treatment guidelines for avulsed permanent teeth with an open apex if the tooth was replanted immediately by the parent or the patient. Clean the area with water, saline or chlorhexidine. Verify the correct position of the replanted tooth both clinically and radiographically. Leave the tooth in the jaw except where the tooth is malpositioned. The malpositioning needs to be corrected using slight digital pressure. Administer local anesthesia if it is required, and again without vasoconstrictor. If the tooth or teeth were replanted in the wrong socket or rotated, we can again reposition those, and we have that window of 48 hours post-trauma available. Stabilize the tooth for 2 weeks using a passive flexible wire of a diameter up to 0.016 inches or 0.4 millimeter. We are talking about the tooth with an open apex. The tooth is immature. Suture gingival lacerations if present. Initiate root canal treatment within 2 weeks after replantation. Administer systemic antibiotics. Check tetanus status. Provide post-operative instructions, and then there will be a follow-up. Certain things we need to remember. Pulp revascularization, which can lead to further root development, is the goal when replanting immature teeth in children. The risk of external infection-related inflammatory root resorption should be weighed against the chances of revascularization. Such resorption is very rapid in children. If a spontaneous revascularization does not occur, epexification or pulp revascularization or revitalization technique should be initiated, or root canal treatment should be initiated as soon as pulp necrosis and infection is identified. In immature teeth with open apices, there is a potential for spontaneous healing to occur in the form of new connective tissue with a vascular supply. This allows continued root development and maturation. Hence, endodontic treatment should not be initiated unless there are definite signs of pulp necrosis and infection of the root canal system at follow-up appointments. Open apex tooth has been kept in a physiologic storage medium or stored in non-physiologic conditions, and the extraoral time has been less than 60 minutes. Revascularization is possible. If not occurring, then epexification or the pulp revascularization technique can be followed. And if the extraoral time is longer than 60 minutes, poor long-term prognosis is anticipated. Local anesthetic considerations in these cases. There are concerns as to whether there are risk of compromising healing by using a vasoconstrictor in the anesthetic solution. However, there is a little evidence to support omitting a vasoconstrictor in the oral and maxillofacial region. Regional anesthesia, for example, infraorbital nerve block, may be considered as an alternative to infiltration anesthesia in more severe injury cases and must be determined by the clinician's experience of providing such block injections. Stabilization of the replanted teeth. An acceptable splint should meet the following criteria. It should be easy to fabricate directly in the mouth without lengthy laboratory procedures. It should be able to be placed passively without causing forces on the teeth. It should not touch the gingival tissues causing gingival irritation. It should not interfere with normal occlusion. It should be easily cleaned and allow for proper oral hygiene. It should not traumatize the teeth or gingivae during application. It should not allow an approach for endodontic therapy. It should be easy to remove. The splint should also allow mobility of the replanted tooth that is comparable with the normal mobility of the tooth. Rigid stabilization seems to stimulate replacement, resorption of the tooth. You can even use the orthodontic brackets with the wire as a splint, or you can use a wire with the composite resin to splint. The bonded resin and wire splint satisfies all the criteria just described. It can be used in most situations requiring the stabilization of one or more teeth if sufficient sound teeth remain for anchorage. Follow-up. Replanted teeth should be monitored clinically and radiographically at 2 weeks when the splint is removed, 4 weeks, 3 months, 6 months, 1 year, and yearly thereafter for at least 5 years. You have to monitor the patient. Clinically and radiographic examination will provide information to determine the outcome. Evaluation may include the findings described below, like for open apex teeth, there is always a favorable outcome. Closed apex, asymptomatic, functional, normal mobility, no sensitivity to percussion and normal percussion sound, no radiolucencies and no radiographic evidence of root resorption. The lamina dura appears normal. Open apex, asymptomatic, functional, normal mobility, no sensitivity to percussion and normal percussion sound, radiographic evidence of continued root formation and tooth eruption. Pulpal canal obliteration is expected and can be recognized radiographically sometime during the first year after the trauma. It is considered to be the mechanism by which the pulp heals after replantation of avulsed immature permanent teeth. For the closed apex, patient may or may not have symptoms, presence of swelling or sinus tract. The tooth may have excessive mobility or no mobility, ankylosis with high-pitched metallic percussion sound, presence of radiolucencies, radiographic evidence of the infection-related inflammatory resorption, ankylosis-related replacement, resorption, or both. When ankylosis occurs in a growing patient, infraposition of the tooth is highly likely to create disturbance in the alveolar and facial growth over the short, medium, and long term. Open apex, the patient may or may not have symptoms, presence of swelling or sinus tract. The tooth may have excessive mobility or no mobility because of ankylosis with high-pitched percussion sound. In the case of ankylosis, the tooth may gradually become infrapositioned. Presence of radiolucencies would be also there. Radiographic evidence of infection-related inflammatory resorption, ankylosis-related replacement or resorption, or absence of continued root formation. So it is replacement resorption or ankylosis related resorption or absence of continued root formation. When ankylosis occurs in a growing patient, infraposition of the tooth is high, likely to create disturbances of alveolar and facial growth over the short, medium, and long term. Long-term follow-up. A long-term follow-up is required to keep an eye on developing complications like loss of replanted tooth or development of infraocclusion. Usually, people ask a question like whether the intrusive luxation or the extrusive luxation or avulsion, which has the worst prognosis. It is the intrusion, where the chances are that the pulp fibers are going to be necrosed very quickly because of the intrusive force, and there will be a pressure on the pulpal fibers or the even the neurovascular bundles which are entering the pulp from the foramen, so they are going to be under pressure. So keep in mind the worst trauma is intrusive luxation. Thank you very much, and I will be definitely coming back with other lectures for you as well. So hopefully you like my lectures. Thank you very much.